of health economics in the healthcare systems with a global experience from the UK, because as mentioned, I am based in the UK. And I would start by talking about what is health economics. Health economics, according to the first definition of Arrow in 1963, is the application of the economic theory, of the models and the empirical techniques to the analysis of decision-making by individuals and healthcare providers and governments with respect to health and healthcare. So it is a part of the economics that studies behaviors of people, but also of clinicians and organizations in healthcare system to understand how, for example, obesity and other behaviors can influence healthcare. It is a very broad topic which explore what is health and what is the value of health, what are the determinants of health, how, for example, health can impact on other dimensions such as work, for example. What are the characteristics of the demand for health and the supply of health, so how healthcare is supplied. It also explores issue regarding human resources, and so, for example, workforce implications, in particular healthcare setting, medical insurance, the imperfection of health markets, lots of topics about public health, and so how behaviors such as smoking cessation, but also vaccination, which is very common nowadays, can influence health and how it can be provided. It also looks at efficiency and equity, at health and the economy in general. And there are parts of health economics which are more on health statistics and econometrics. And what I do generally is economic evaluation and pharmacoeconomics and HTA. Now, there is always a bit of a misunderstanding about the role of health economics. Health economics is not necessarily about cutting costs, is not about cutting resources or reducing services, and not necessarily cost saving in the short term, at least. So it is not about choosing the best, the cheapest option, but the best option that improves people's health and well-being and also reduces health inequalities. So health inequalities are really important in health economics as well. The UK health system is a devolved matter. Each country in the UK have their own system of publicly funded healthcare. They are funded by separate governments and parliaments. So we have England, Wales, Scotland, and they work somehow independently, together with smaller private sector and voluntary provision. Each country has different policies and priorities, and a variety of differences exist between these systems. And I guess this is very common also in other healthcare systems around the world. Just to say, we have very much free healthcare provided by GPs in primary care, hospitals in secondary care and emergency, free community pharmacy with some private owned community pharmacy, free ambulance services, and NHS or private dentist. And these are funded by the clinical commissioning groups, which get obviously funds from the NHS and the commissioning board. So just to say that this is basically the healthcare system in the UK. And in the UK, as well as in other countries globally, the population is increasing. These are the projections of the UK population from 1960 up to 2040. As you can see, there is a steep increase. We will reach almost 80 million in 20 years. But not only we are more, we are also getting older. So if you compare the situation in 2016 with the one in 2036, from 1,035,000 over 85 years old in England, we will reach around 2 million elderly people by 2031, with obvious consequences in terms of needs of people. Now, NHS resources are allocated between CCG's area according to a formula that estimates the relative need of the population. So talking about needs vary according to age and sex, and the very young and the elderly have the highest need. And so here you can see what are the costs per person in UK based by age, and as you can see, by getting older, you need more health care, both for females and males. And so this has obviously some implications in terms of how resources needs to be allocated. So in the UK, there is more life expectancy, but it doesn't mean that we are healthier. As I said, we are getting older, and this obviously has to deal with elderly related diseases and dementia, for example. We also have lots of avoidable mortality, including cardiovascular disease, obesity and diabetes, drug use disorders, infections, injuries, cancer, obviously it's one priority, and also respiratory diseases. Next to it, there is disability. Many people are becoming disabled because they have chronic conditions, and mental health is another very serious issue in the UK, but also worldwide. We estimate 1 in 4 people have mental health in the UK, 10% of children develop mental health, and therefore 19 billion pounds are spent every year only for mental health. There are lots of implications in terms of equity, especially for what concern tobacco, alcohol, obesity, and children's health in deprived areas. And these are very common issues that you can find around the world. Now, why is health economics relevant? To my students, I keep presenting these slides where there is the trend of a number of elective cataract, hip and knee procedures from 2002 and 2012. As you can see, there is an increase at some point, and then a steep, steady trend following 2009. 2009 is the time where we had one recession, and as you can see, despite the population is aging and getting older, and these are all interventions addressed to elderly people, there's not been an increase in these interventions, showing that these operations have been rationed. And so there is obviously a scarcity in terms of budget, and we need to cut here and there. Now, why health is an economic good? It's an economic good because it is scarce relative to our wants for it, because the resources that we use to produce healthcare services are obviously finite, and more of these resources can be devoted to the production and the consumption of healthcare only by moving these resources from one sector to another, so taking from education and defense and other sectors of the economy. And also because our wants for healthcare are infinite. No healthcare system anywhere in the world has achieved the level of spendings which is sufficient to meet all the citizens' needs for healthcare. Then the implications obviously are profound, because it means that we have to make choices about what quantity and what mix of healthcare we need to produce, and who pays for it and how it is distributed. So these are all topics in health economics that we need to take into account. So there are some basic questions as health economists that we try to answer every day. The first is, what is the combination of healthcare and non-healthcare goods that should be produced in the economy? How much do you allocate for healthcare? Which particular types of healthcare should be produced? Should we invest more in prevention, for example, in diagnosis, in vaccination, in treatment of diseases, end-of-life care? And then what resources in terms of inputs should be used to produce these healthcare services? Should we employ more staff? Should we buy more drugs? Should we get more technological devices and robots, for example? And finally, who should receive these services? Should we give these services to everybody, no matter what? Should we only concentrate on those who need the interventions the most? Or should we also make an allocation based on their ability to pay, and so give free healthcare only to those who cannot afford to pay privately? And there is a fundamental concept I mentioned yesterday about the opportunity cost. The opportunity cost of using resources to produce a good or service in healthcare, but in any sector of the economy, is the benefit that we lose by not using these resources in their best alternative way. So let's assume we have £3,000 to pay for one bypass heart operation. The opportunity cost is what we lose in terms of benefit by not using this amount of money to, for example, provide a third of a cochlear implant, 11 cataracts removal, 300 vaccinations, meals for children, paying a support teaching assistant for a year, or a hundredth of a Challenger tank for defense. So there is obviously an implication. The resources we use in one sector cannot be used in other sector of the economy. And so the consideration of opportunity cost means that the production and the consumption of healthcare incurs real human costs, as well as creating real human benefits. So in judging the use of resources in economics, we are very much interested in efficiency, which is the allocation of scarce resources that maximizes the achievement of the aims. We're interested in equity, so fairness in the sharing of healthcare resources between people. Whereas in health economics, we also look at the effectiveness of intervention. So the extent to which healthcare services actually improve health, and also an ethical implication. So yesterday, Munir presented this slide. This is a slide I keep using for my students to tell them that if we have a bed, not only we need to understand where these beds should be placed so that it is used in an efficient way, but we also need to take into account of who is the person who's left out, because we are really interested in equity issues. So what's the role of health economics? Health economics should be used to invest in prevention, and it protects in individuals and their health, but also wider part of the economy, because if we do prevention, obviously we can decrease NHS costs, social care costs, we can decrease productivity losses due to the fact that people, if they're sick, they cannot go to work. And also the cost for the wider economy. So for example, if you think at alcohol or drug abuse, to all those crimes related to bad behaviors. So health economics help understanding the effectiveness of an intervention, when the period of the effectiveness, when does the effectiveness kick in, how long it lasts, what are the costs of the intervention, but most importantly, what is the perspective we're adopting, and so what benefits should we include in the model? And I will explain more later about this. Now, are we getting better if we spend more? There is a geographical variation in health spending and outcomes between areas in the UK, but this also happens worldwide. And there is a central issue in health policy that concerns the extent to which spending more can provide more benefits in terms of health outcomes for patients. Well, the evidence concerning this relationship between how much we spend and how well we are is somehow inconclusive, because proving this causality is very difficult. For sure, if we spend more, we're going to get an improvement in outcomes, but we can see that spending is higher in those areas with poorer outcomes. So we may not really observe the true effect of spending on health. And in this sense, we need to allocate resources in an efficient way. And the role of the National Institute for Health and Care Excellence in the UK is to make decisions on whether drugs, treatments, interventions should be available through the NHS, based on evidence and from input from patients, health professionals, experts, and manufacturer, providing independent cost effectiveness analysis and producing guidelines. And I will talk about it in the next presentation. So to conclude, the UK population is increasing, we are living longer, we are getting older, and therefore the health needs are changing and are increasing. The resources are scarce, and health economics has an essential role globally in investigating the efficiency, the effectiveness, the value and the behavior in the production and consumption of health and healthcare, and also in helping decision makers allocating resources across healthcare interventions and policies. There are some structures in place that can support this, at least in the UK and in other countries, but there is still a lot to be done, and it obviously requires collaboration among economists, clinicians, patients, and the stakeholders. Thank you so much.